This podcast represents my opinion and the opinion of my guests. This is not medical advice, and I am not establishing a patient-physician relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only. And because each patient is so unique, please consult your healthcare professional for any medical questions you may have.
Welcome back, everyone, to another episode of the Not Your Doc podcast. I'm your host, Vanessa, and today Dr. Tadros and I are joined in the Midwest Institute for Hearts and Minds studio by a very special guest.
Yep.
Today we've got Dr. Tadros as co-founding partner at the Ketamine Clinic, Midwest Institute for Hearts and Minds, Dr. Foroughi.
Hello, everybody.
Welcome.
Thank you. So excited to be here.
Yeah. Welcome to the podcast that you sponsor.
Oh my gosh.
It's nice to have you here. Check out what's going on.
That's right. Looks good so far.
All right, that's awesome.
Check under the hood.
Yeah, for sure. So today we're going to take a little departure from our normal non-ketamine related content. I think we sort of said from the outset that this podcast is mainly not going to be about ketamine.
That's right.
But today we're going to talk about ketamine, and Drs. Tadros and Foroughi are going to tell us about Midwest Institute, how it came to be, and we're going to hear more about the work that they're doing providing ketamine treatment to patients in St. Louis. I think this will be a really useful opportunity for our listeners who are either friends of people who have been patients with us, our current patients, prospective patients, to sort of get an overview directly from the co-founders' mouths about, what we do here, the purpose behind it, the results we're seeing. So I'm looking forward to that discussion with y'all today.
It's a nice opportunity for us for Vafa and me to review how we got here.
Yeah. Do a little reflection.
That's right.
We love that.
If I remember correctly, and Chuck, you're going to have to fill in because of my memory about this, but it's all started with you giving me a call and saying that, hey, can we meet at Starbucks? I want to talk about something. And I was wondering, what is he going to talk about? Now, we've been friends since med school in 1990, and we've met together.
So at SLU, you met at SLU Medical School.
Right.
Yeah.
Okay.
We went. Vafa was from Utah, the great state of Utah, and I was from Illinois, and we went to school together at St. Louis University School of Medicine.
the big city.
That's right. This is so we went there from '86 to '90. Vafa was in a hip crowd that I didn't speak with.
I don't know about that. I have the opposite memory of that.
But anyway, we didn't. We just were colleagues. We were not buds and chums.
We met occasionally as a group of alumni in town. We would grab dinner once in a few years.
Okay.
And we crossed paths a few times at Barnes and Nobles.
That's right.
Seeing each other work on different things. We're both kind of entrepreneurs at heart.
Yeah.
We have dabbled in many different businesses, and I think that kind of was one of the key ingredients of getting the ketamine clinic started, having that passion and fire inside us to do something different.
We stayed after med school. You had to do a residency. I stayed in town for internal medicine. Vafa stayed in town for anesthesia. Afterwards, we stayed in town for practice, and so we continued meeting with each other as friends with other group members. And it turns out that it happened to be that. I don't know if it was NPR or some CNN, but I had read something about ketamine. My mother, back in the 70s, we used to drive from Southern Illinois to St. Louis to get ECT because she had bipolar disease and severe depression. And so as an internist, I was always interested in mental health. I never could separate it from the rest of my patients' needs and problems. And so this was another tool. It just happened to be that about 2014, we were hanging. I saw something, like I said, CNN or NPR, and ketamine. I'm a physician. I had not used ketamine myself, except actually we used animal studies back in the old days. Ketamine for animal studies, and it is a dissociative anesthetic, but initially it's an anesthetic for veterinary medicine anyway. But it's been used for humans for decades around the world. And it just happened to be another tool. It was very novel.
So this was 2014 then?
2014.
Okay, and so you heard something about it in the news or whatever, and so you called Dr. Foroughi? Is that how that worked?
Right. I think it was early 2015. You called and said, hey, can I talk to you? I had no idea what you want to talk about. You sit down in the corner at Starbucks and says, hey, have you heard about ketamine? Yeah, I've used it a few times. doing trauma cases
Yep.
in the hospital when we couldn't use other anesthetics. It was a good agent to use in those situations. I said, no, that's the only time I've used it. And he said, what about this? And he continued to talk about mental health and issues in your family, which, by the way, my grandmother had ECTs long term for depression. She lost a son, and she never recovered from that with her depression. So that was present in our family. I said, okay, well, I'm here for you. I thought I was going to be more of a advisor, consultant to you, whatever project you were going to do. And then we walked away and said, we developed some tasks to do.
That's right.
I was reviewing our emails and the text back and forth, and we kind of got excited. I got excited because now we got things to do and on a venture. And about 10 days later, my brother calls me. He's a pharmacist in Utah, has a little company. And, hey, how you doing? Fine. He says, hey, what do you know about ketamine? I said, well, wait a minute. 10 days ago, somebody asked me, hey, what do you think about ketamine? What are you talking about? He said, well, some nursing home has asked us to mix some ketamine up for them for some depressed patients. I said, I'm not going to wait a minute. This is too weird to have this in a matter of 10 days. So really got serious after that. And then the next phase of our research started.
Yeah, so you started reading articles. There's popular press, but you have to look at some of the scientific articles. Sure. Ketamine was developed, I think it was Park Davis. It was initially in Europe, and it was a derivative of PCP.
Angel dust.
Angel dust, yeah, it was supposed to be, they were going to try to use it as an anesthetic, but angel dust, back in the old days, it gave too many weird experiences.
Intense psychosis, right? I mean, like hallucinations.
Right. Hallucinations and stuff. So they were trying to develop a cleaner product, what they call cleaner, pharmaceutically cleaner in terms of the side effects. And so they developed it, and it became a vet med drug, and it came to the States. And eventually it was used like a lot of vet med drugs. It was a part for work in humans. And the great thing about it was very safe to use. It doesn't depress respirations. It doesn't remove the gag reflex, a protective reflex to protect your airways, and which is a big problem with whenever you use anesthetics. But anyway,
and it supports blood pressure.
Right, elevates blood pressure as opposed to drugs. That's right. So and it's actually a WHO necessary drug. It's used in the military. It's used for pediatrics. It's used in burn units. So it's used widely for many decades. So it had a nice safety profile. But anyway, so people accidentally, over many decades around the world, people accidentally found that if somebody went under anesthesia, under ketamine anesthesia for major surgery or procedures, they'd wake up, and if they were previously depressed or previously had neuropathy, nerve problems is another thing that's used for nowadays, is for certain types of chronic pain, that they would wake up and for days to weeks, they would be less depressed or less pain. So it was accidentally found, and they eventually decided you did not have to knock people all the way out to get these benefits. Yeah. And so if you use small doses repeatedly, then you could potentially help people significantly. It was another tool. It works through the neurochemical process. That's glutamate, which is the excitatory, the main excitatory neurotransmitter in the brain. So it works differently than SSRIs, like the Prozacs and Zolofts and Paxils, and works different than the SNRIs, like Cymbalta and Effexor. So it was another tool. But the great thing about it was that people would not use it outside. You could do it in the clinic, and you don't have to give them anything outside. So all the side effects that you typically would get with an antidepressant that might be helping them, or an oral antidepressant, if you can give it just as an IV, that's how we started using it, because that's how it's being used. And we could talk about that in a second. That people would not have all the side effects of the drowsiness and the appetite and all sorts of stuff like that.
Sure.
So yeah.
So I guess I want to back up and ask you, Dr. Foroughi, was ketamine frequently being used in anesthesia, or was it kind of like a special case?
I think I used it in, I guess, my 11, 12 years at that trauma center, maybe 3 times.
Okay.
So
did you ever directly observe that antidepressant effect in your patients?
No, because we didn't follow patients long enough afterwards, but I did observe the extreme dissociative effect of it as some of these patients were, taken back to the recovery room, waking up, they would really freak out. I had one patient start screaming on the way to recovery room, incoming, VC, incoming.
Oh, wow.
I mean, he had a flashback to his Vietnam era
Wow, yeah.
time. So there was, unlike other
Sure.
anesthetics as they woke up. So
Sure.
I
And
did
those are,
observe
and
that.
this is an actual anesthetic dose of ketamine, whereas the way we use it in our office would be a sub-anesthetic amount, right? Yeah,
extremely
okay,
lower.
much lower doses.
Extremely low. Yeah, we use that ketamine not as necessarily maintenance of anesthesia, more of an induction to start
Okay.
the takeoff of anesthetic, because that's the most vulnerable period as far as when, let's say, you have a trauma patient,
Right.
Because you really depress a lot of things for a short period of time
Mm-hmm.
to achieve that kind of cruising altitude of anesthesia. So that induction agent hung around, and the effect of that dissociation
Got it.
was observed at the tail end of it.
That's interesting. So, you guys both kind of agreed that this might be an interesting tool. Did you like attend meetings or conferences or anything to learn more about how it was being
Well,
used?
I'll say a piece of it because you did, I think, a lot of the research.
Yeah.
But we kind of researched for about a year actually.
Yep.
And we went to the first
Yep.
ever, if you will, ketamine conference that was for ketamine providers, and we were one of 12, and we were not a ketamine provider. We
Yeah.
kind of got ourselves in with kind of being nice, and you had
right.
a inside friend, if you will, a doctor from Boston who was extremely helpful. I think she
was.
had a lot to do with us getting started, because
Yep.
often doctors, when they're starting a venture on their own, they don't want to share too much information.
Sure,
They
yeah.
say, hey, I created all this work and templates and recipe, if you will. It's like a restaurant. I'm not going to give you my recipe away. But this doctor was extremely helpful, extremely helpful.
Right.
You reached out to a
did.
number of places,
Yep.
dozens, and nobody would respond to you.
couple-
And this lady
s-
did.
Yep, one of the anesthesiologists from Boston, like you said, and Isabel, and then one of the anesthesiologists from Washington State. Anyway,
And so
Portland, yeah.
these were physicians that you knew were using ketamine to treat mental health issues and
depression,
chronic
right?
neuropathic
Depression
pain. Okay.
and anxiety
Okay.
and neuropathic pain. That's
Gotcha.
right. So they kind of, once again, what had happened, unlike FDA-approved products and how we use ketamine, and all the people in the United States use ketamine for depression, anxiety, et cetera. It's called off-label use, off-label from what the FDA has approved it for. It's FDA approved it for anesthesia. We're using it for non-anesthesia purposes. So it's legal, it's common for all sorts of products, antidepressants, anti-seizure medicines, all sorts of products.
But it's not a standardized treatment the same way
That's
other
right.
other medications.
So
are.
what
Okay.
happens, unfortunately, whenever you have a product like this, which is many years, so therefore it's generic and it's off-label, is that nobody wants to spend money to do the expensive big
Right.
trials to get FDA approval for
Right.
depression, et cetera. So what comes out is that we get kind of a consensus. We do best practices, and so we learn from other physicians. We go to meetings and see how it's used, et cetera. But there's no humongous studies that qualify it for FDA approval for treatment for depression or anxiety or PTSD, et cetera.
Sure.
But people around, it turns out when we went to the first conference in San Mateo, a little south of San Francisco, that it turns out that people for years had been using it for all sorts of conditions. And the people include ER physicians, ICU physicians, psychiatrists, anesthesiologists, pain management specialists. So people throughout the world. We had people from New Zealand. Eventually, when we kept going to meetings, people from New Zealand, people from Russia. So people have been one of the physicians from Florida that we went the first couple of meetings had been doing it for 20 years as an anesthesiologist for pain. So people had kind of pieced it together on their own and read some literature, and so that's what we were doing much later than these kind of leaders.
Sure.
But anyway,
was it a daunting task to consider doing something like this here in St. Louis? We're probably not known as being the most, progressive city in terms of using, mind-altering substances to treat disorders.
Well, so the good news is that it's used by the medical profession for anesthesia, so it was known for safety, et cetera, like that. And at the time that we started looking, WashU was doing a study, like a 97-hour continuous IV infusion for depression in inpatient. So it was a very small study, and that was about the time that we were looking into it back in 2014, 2015, and we finally started in 2016. But what I recognize is that when we talked to our insurers, they did not know what we were talking about.
Yeah,
And
yeah.
so, and of course, the drug supply companies are used to doling out small amounts to anesthesia groups and
That use it infrequently
right,
for trauma cases and whatever. Okay.
and veterinarians and stuff like
makes
that. So that was there was a shift, a paradigm shift in the United States.
I have to tell you that Midwest and conservatives, that was never on my radar.
Yeah, okay.
We live. It's like we live in neighborhoods. We live in
Sure,
small
yeah.
areas, and I never felt that there was going to be any pushback or any kind of image issues, things like that. So that is absolutely not. I mean, hypothetically, I could see that if
Sure.
someone wants to say, "Oh, you're progressive," or Portland. Maybe it started there. I don't know, but I never for a moment felt like, "Oh my God, this is Midwest. We can't do this."
Yeah, yeah.
But I will tell you, I was a little paranoid just because, here's a street drug. It's really not known. I felt like, and it was proven later, that not too many psychiatrists necessarily were supportive of it for various reasons. At least the bigger names or the leaders of the society, if you
Well,
will.
maybe they just weren't as familiar with it, right? It was really new to everybody.
I think partially not familiar, but partially they're just, no, this is not in our way of thinking and pharmaceutical pipeline.
Sure.
And let's be honest, I don't want to be cynical, but this is a very cheap drug.
Right.
And so there's a
certainly
lot
no
of
profit
forces
motive, yeah.
lined up against it. So I was paranoid. I was a little nervous. I just kept thinking someone's going to, if we open this, we're going to have a line of people who are going to abuse it standing in the parking lot. And the DEA is going to come through. And I do remember, again, doing a little bit of research for this, I wanted to call DEA myself. I wanted to take the load. So I called the DEA, and I found the email that I wrote to myself about the car, and I sent it to you.
Yeah.
I have the agent's name, so I called and waited online, and the DEA agent came on, and I said, "This is what we're doing." He said, "No, what is it, and what are you doing?" And it was a lot of questions. I spent time educating
That's right.
him.
Them, yeah.
And
That's great.
I already knew everything he was going to tell me. He said a couple of things that obviously were important and was not directly, but on my radar, the way the ketamine has to be locked up and so on and so forth, which is by the books, if not more, but also hours of operation, security to the access to the place, so on and so forth, which was already established.
Sure.
But I made sure that I started talking to the agent because that was my worry.
Yeah.
That as soon as our name got, we were going to be abused
Sure.
by not up and up individuals, and then also people were going to say, "Well, what are you guys doing? You're selling what in the parking lot?" Things like that.
Yeah.
The nightmare that you hear on the news.
Unfortunately, when VAFA says a street drug, it's any drug that's prescription eventually that's controlled substance eventually makes its way to the streets, whether it's directed from original manufacturers or people make it elsewhere, fentanyl, oxy, etc. Sure. So that's one of the things. So fortunately, because the way we use ketamine, which is just the two physicians in the office, and we don't prescribe it for anything or anybody else outside the office.
It's a very secure way to do it.
Yeah, it was very. We kept everything very tightly controlled.
Sure. Okay, so once you decided to jump in with both feet, what were those early days at the clinic like? Where were your patients coming from? What were their what kind of things were you treating for them?
Well, the lead up to our first patient was, any kind of business, the challenge is not the big questions. It's the little questions. So if you're opening a restaurant, it's what kind of stove we're going to buy.
Yeah.
It's not like what's going to be the menu. We're going to have
Sure.
Italian food, and that's easy. But so there was a lot of, as I was again reviewing our path to here, there was a lot of little questions that had to we go through, and that was kind of rough.
Yep.
Waiting for equipment, choosing the equipment. From a legal, accounting, supplier, so on and so forth. So that took a while. I was again reviewing it. One of the hardest things, at least from my point of view, was this sounds silly, but finding the right chair and recliner.
Yeah.
For the balance of comfort and safety and patient accessibility and so on and so forth. We couldn't put a gurney. That's cold.
Sure.
But gurney is the ultimate. Patients flat. So I have lots of pictures of myself going to different furniture stores and laying on it and having the salesperson take a picture of me, see what I look like and how I fit and so on and so forth. So it was hard find the chair.
So to give patient, like anyone who's listening to this, a mental picture of our clinic, in case you're not familiar, patients during infusions are in private patient rooms and they're seated in a recliner and hooked up to their IV during the infusion. So it's important for them to be somewhere stable and comfortable, but also,
accessible
for you guys.
Yeah,
absolutely.
So yeah, I remember the first patient. Actually, it was a patient of yours.
That's right.
A lady who
She was.
And I do remember in the corner of my eye, you were concerned, rightly so. You didn't know what to expect.
That's right.
And you were in the room, and kind of watching, standing by to help. I remember brought her in and put the monitors on, and everything worked okay. Blood pressure went on, and so and definitely want the first IV to go in well. You can never predict what kind of hurdles you're going to face. So, in order to start an IV, normally your patient is on a bed, very accessible. But, on a recliner, it's a little different. It's difficult to kind of get close and have access to the arm. So, but the IV fortunately went in very easily. And we started kind of a background light and music, and infusion started. I do remember looking at you, and there was a huge load off your face, and you almost surprisingly / shockingly said, "Well, that went easier than I expected." So I think you were expecting a little bit more drama, if you will.
Yeah.
Now,
Yes.
obviously, it was normal to me. Here's a patient. Let's start an IV, give some drugs. And I see it. You're being kind of concerned, but it was a huge weight lift off you.
That's right. This is an outpatient office setting, and it went extremely well. And we've been with a lot of planning, a lot of good staffing. We've done extremely well for 6 years now of giving. 2016 is when we started.
Yep.
End of 2016. Yeah.
So at that time when you all first started, this was in Dr. Tadros. This is in your former primary care practice space, right?
Which is the current one.
Which is the current. It's still the current space,
That's right. That's right.
But you were dedicating like one room, basically.
We had one room.
Well, when I told you about the chair being a challenge, the other challenge before this was finding a space to do it.
Yeah.
We looked at looked at pictures that we had taken.
Did a couple of years.
A couple of years. We looked at many spaces, all sorts of things, collaborating with other people, getting our own space, so on and so forth. And we had some front runners, if you will, and then one day out of the blue, I got a gift from heaven. Chuck said he's going to his own office. That's right. Going solo practice.
I've been part of medical groups for many years, and I've decided to get a space, and I just chose a space that had extra room that I would not need for my primary care practice, and it worked out well.
Yeah, and then we started taking one of your four rooms.
One of the 4 exam rooms.
And then 4 exam rooms, and
eventually went to
we
2.
We paid a quarter of the rent.
That's right.
And so, as a side, anyone trying to start business, my advice to any entrepreneurs out there is the number one key reason to succeed is to control your costs up front. And it's going to be very hard because you're going to be full of hope and excitement and joy, and let's spend here and let's spend there. How much is another 100 here and there? Control your costs, okay? And so we were fortunate to be able to effectively have a great clinic, beautiful setting, but really pay a sublease, a small amount. So we got big space, expensive space for really a small amount. And the labor cost was zero because I was the only person. I didn't take any money home. And so I guess controlling costs, no labor costs, minimal rent, you can't fail.
That's right.
That's awesome.
You can go through hardships pretty easily. Yeah.
So let's talk like the first couple of years where you just in a couple of rooms still, and kind of like a handful of patients would be in the treatment pipeline at a time. Is that kind of how it went for a while?
We did 2 days a week. We did Wednesdays and Saturdays, and one room, just me doing one after the other, hour and a half slots. And I do remember like a busy day would be like, oh my God, we have 4 patients, which is, that's 6 hours. But
it's a super light day for us now.
Right. More like 2 or 3 cases. And one of the interesting things that now makes total sense, but back then we never could predict it. And this is another thing about doing a business. You think you know everything, you don't until you start doing it. Either the first day or first year is again, our volume was a lot of new patients. We really never thought that we're going to have maintenance infusions and booster infusions, things like that.
Yeah.
Well, we knew about it, but we didn't think it was going to be real.
Or a major portion of our
Component,
business.
big
It
component,
turned out to be a major portion. So when that started coming on board, our Wednesday, Saturday wasn't going to work because we had these kind of series that were kind of had to stay in rhythm and cannot be interrupted. And we can talk about that later.
Yep.
But then we have all these patients who would call us and need a maintenance infusion. Where do we put them? Well, let's start a third day. So that's when Mondays came, and they were supposed to be exclusively for maintenance infusions. That's how Mondays go. So we started expanding basically by 50%, going from 2 days to 3 days.
Sure, yeah.
And then we went to a second room by then, so.
All right,
It was organic growth, as they call it nowadays. Yeah.
Absolutely. So let's kind of jump forward to how you describe the clinic now. This is the longest running ketamine clinic in St. Louis. I know you've got a way of describing it.
Yeah,
right?
the longest continuously running ketamine clinic in St. Louis for IV, and now we added intramuscular ketamine about a year and a half ago. So we do IV and IM ketamine, and we started 6 years ago with the IV, and a year and a half ago we added in the intramuscular during the pandemic.
Do we have like a ballpark idea of how many infusions we've done over that time, or how a total number of patients since you opened? Yeah,
I'd say about over 3,000.
Yeah,
definitely over 3,000.
Well over 3,000.
Yeah, that's a lot.
Yeah.
Yep. A lot of IV starts.
Yeah, a lot of IV starts for sure.
And then a lot of clinics were there. I think before us, they came online after us, but like I said, for various reasons, they did not succeed. And I think we have a number of reasons we are very successful, and we can touch on that later. But I know why the other clinics failed. I think they just didn't look at it correctly through a business lens, if you will, and didn't do the things that they needed to do. So, but those, we had a luxury, like I said, low rent, no labor cost, and really a labor of love. I think I was lucky to find Chuck because a lot of similar personalities were kind of strangely passionate about what we do, and our most valuable resource, our time, I'd like to say we're very generous with it.
Yeah, absolutely.
When I would refer patients to Dr. Tadros as an internist, they would come back to me and say, oh my God, he has spent so much time with us.
Yeah.
That's a key secret ingredient that nowadays is so hard to come by.
Very hot commodity.
We had a very good and compatible personality, and that's what it takes to succeed, in a kind of partnership, if you and anything, restaurant. And
you can't early on. You can't hire that out. You have to spend it. It's your own time. You can't give that time. You can't hire it away that early.
Right.
For sure. So where do we see the majority of our patients coming from now?
Word of mouth, and some of the psychiatrists.
I think a lot of self kind of driven research, at least anecdotally. We looked at that data a while back, but I think it may be time to look at it again. The field changes, it seems like, so much.
Right.
But anyway, to me, I think our number one is people doing a lot of research, people in many areas in healthcare taking ownership of their own treatment and healing. Most of the time it's good. Sometimes it does go kind of sideways for patients. But I think a lot of our patients come with their own kind of...
So they do a Google search. It's typically ketamine in St. Louis, or depression and ketamine in St. Louis.
Resistant depression. And then, often they check in with their mental health providers, kind of get validation, which is what we kind of insist. We don't want to have a patient de novo coming in. We certainly have turned patients away who, as a first line, have... look for ketamine.
Sure.
This
absolutely.
This is treatment for treatment-resistant depression, for example.
Absolutely.
Which is not a first line of defense.
That's right. We want, whenever I consult, I've done 100% of the consultations myself. For when we first meet new people face to face or Zoom during the pandemic, is that I want to make sure that they have a team, which includes oftentimes a primary care physician, therapist, psychiatrist, one or more of these, because, like I said, we narrowly use our tool, our time, and the ketamine, and so I want to make sure as an internist, I want to make sure their whole care,
Sure.
not just which includes comprehensive care of their mental health and all the other medical problems which do impact on mental health and chronic pain. I wanted to make sure other people are on board and know that the patient is receiving ketamine from us, et cetera. So we'd like to make sure we know that the patient understands that they have to inform the other practitioners, and that we're in communication if we need to.
Yep. So I think that's a perfect segue into, what we're currently doing now with regard to our treatment process and protocol. So when someone first reaches out to our clinic, I'm typically the first person that they interface with. So they'll reach out. I'll send them some preliminary information about our treatment process, the protocol, and pricing. They send us back some general information about themselves, and then I get them set up for a consultation with you, Dr. Tadros.
That's right.
And I know that some of the main purpose of that conversation is to really get to know the patient, understand what's bringing them here, what they've tried in the past that has or hasn't worked for them, getting that kind of holistic healthcare picture of them as well, learning about their support.
That's right.
And then ultimately you can determine in partnership really with the patient if they're going to be a good candidate for ketamine treatment. So can you tell us more about what that consultation is like?
Yeah. I approach it from an internal medicine standpoint with mental health attached. So oftentimes the patient's there with a loved one, relative, friend. So what I'm interested in is literally everything. I spend about an hour and a half, sometimes up to 2 hours in one session, the first session.
Yeah. Which amazes people, by the way. Like Dr. Foroughi's patients would come back to him when he's referring to you as an internist. They come back to me and say, I've never had a doctor actually listen to me and talk to me for that long. So that's medicine even in and of itself, just so you know.
Thanks. But I see all the stories, all the patients' stories are intertwined. I can't differentiate. I can't just let's just talk about depression. Don't tell me about anything else. So I'm interested in everything. I'm interested in where they live and who they're married to, or if they're single, if they have partners, if they work, if they're disabled, if they go to school. I'm interested in their substance use or abuse. I'm interested in their family history. I'm interested in medications, allergies, surgical history, past medical history for all other non-surgical stuff.
Very comprehensive.
So I'm interested in all these things. I'm also interested in how they perceive themselves, how they perceive their disease, what they would do if they felt better. And sometimes with their permission, I'll ask the relative who's sitting next to them or their friend or stuff, what did they see, or what did they have, what have they witnessed? Because sometimes, all of us don't have total insight into ourselves.
Sure.
And certainly whenever people have significant mental illness, it impacts their ability to have insight. Anyway, at the beginning of any consultation, I remind them I'm an internist. My partner's an anesthesiologist. We're not psychiatrists. We're not talk therapists. That's why I want to make sure that you have good people, good team members that are helping take care of you, and we add on to their care. And we're using a tool, ketamine. It's not a cure, but it helps. It can potentially help treatment-resistant depression, anxiety, PTSD, panic in some people, and OCD in some people, and some chronic pain patients, especially people with neuropathic pain.
Can you say something more about treatment resistant? What does that really mean when you think about treatment resistant? What do you mean?
There's not a very hard not a very solid definition. Typically, it's two drugs, oftentimes in different classes, different mechanisms of action, that you are able to get to full doses, which typically takes anywhere from a few weeks to a few months. And if you fail two drugs, fail to get response or remission from your depression, that's what we'll call it treatment resistant. So two drugs.
Yeah.
A lot of people come to us with tried dozens of different doses and mixtures of medicines.
Right.
Sometimes ECT, electroconvulsive therapy, which is shock therapy. TMS, transcranial magnetic stimulation, which is magnetic therapy. So they inpatient stays. So many patients have way exceeded their quote unquote treatment resistant hurdle.
Yeah. Occasionally we'll have patients come to us who this is kind of like their first attempt to really treat their
Yes.
mental health issues because they may have heard about ketamine
That's
being
right.
very different from typical antidepressants, that sort of thing. Why are ketamine infusions not necessarily going to be the first line of defense for treating something like that?
Like I mentioned, it's not a cure, and neither is Prozac, et cetera. So some people can spontaneously, with, I'll say, let's pick 100 patients who are depressed in the United States without anything else, without anxiety, et cetera. About 70% of those people can get better with talk therapy, exercise, sometimes medications. So they don't need ketamine, and you can sometimes be on Prozac and talk therapy for 6 months to a year, and go into remission, and may not need really medicine for ever or for quite a while. So you really don't need ketamine for that. That type of person. Yeah.
Okay, yeah. Is there anything that would disqualify someone from, doing ketamine treatment? Any medical conditions or addiction, anything like that?
Sure. The easy ones are active psychosis. So these are people who are schizophrenic, who are not well controlled. It's not that schizophrenics can't get depressed. It's that if they're actively psychotic, which is loss of touch with reality, those people should not receive ketamine.
Okay.
People who are manic in their bipolar disease. Now, once again, bipolar patients are, the old term was manic depressive or manic depression. And if they're manic, they should not be receiving ketamine.
Right.
Now, a lot of the bipolar patients become depressed and persistently depressed, and they can't get out of it. And those people, what we call bipolar depressed, the depressed part of the bipolar disease, can receive ketamine carefully. Those are the big ones. The other ones that we've chosen in our practice is people who are actively addicted to alcohol, narcotics, are actively have problems with addiction. Those patients we've chosen not to treat while they're actively addicted. If they're in remission and have depression, then yes, we can treat them. So that's generally how I kind of approach it.
But we're not using ketamine to transition someone off of an addictive substance as like a first starting point for treatment of addiction.
Right.
It's a totally different ballgame.
There are some studies being done for those of alcohol and narcotics, and we do not claim to be able to help patients as effectively, because some of these patients need multidisciplinary care and inpatient care, and that's a big deal.
Which just isn't our setup.
We're purely set up as an outpatient.
Okay, yeah. How would you describe our scope of treatment? Like, why? I know we kind of intentionally keep it pretty narrow. So how would you describe it?
What we focus on is the treatment-resistant depression, generalized anxiety, obsessive compulsive, panic disorder, and some types of chronic pain. We do not prescribe or refill people's anything else. Their blood pressure medicine, their Xanax, their Ambien, anything else. That's why they should have their regular physicians or nurse practitioners or physician's assistants still continue prescribing that. So we've narrowed our focus just to the ketamine that we administer within our four walls.
Sure. So I've got a question that I want to throw to both of you too. Because we were kind of speaking before we started recording the podcast about some of our points of difference, like what makes our practice different than maybe some other places that are using ketamine. What would you say our goal is for patients? Like, are we just trying to help somebody's depression get better or to feel less anxious? What kind of actual improvements are we looking at? And I hear you all ask these questions about functional improvements all the time after infusions and after treatment. So what would you say is our goal in treating patients?
Well, when I talk to patients before our first infusion, I do a little mini consult, if you would, for about half an hour to 45 minutes to set some expectations of sort of what they should feel and expect immediately during and after the infusion. And one of the analogies that I use is that ketamine is not a magic wand. It's not a potion that we're going to sprinkle on you and it's just going to fix everything. So I want to make sure they understand that. But what I do tell them, again, kind of using an analogy, set their minds up for the expectation, is that ketamine will give you kind of a brief opportunity to shed some light and find the doors out of your darkness that you're in and get out into the light. It gives you a temporary reprieve of the situation here, whatever that situation is, to make changes, solve issues that have been lingering and weighing on you, personal, family, things like that. So the way I look at it is giving them that brief moment. The other things that, again, I've seen anecdotally through some of our patients, that during these infusions, both during the actual infusion, the period right after it, is they kind of clean house in their mind. Let's say they've had long-standing traumatic experience as a young person, 50, 60 years ago. They're able to unravel that, forgive themselves, forgive others, and unburden, leave that weight down. All these things I tell them, all these things are just nerve cells firing.
Yeah.
And you're
right.
trying to stop a certain group of nerve cells that are weighing you down to stop and replace them with some good subroutines in your head. Yeah. So ketamine, I tell them, allows you a temporary kind of reprieve from that to do those things that you need to do. You just mentioned it a minute ago about physical activity. I say during my talk before the infusions, there's 2 musts. I give you homework. One is physical activity. If you don't do it, start it. If you're doing something, pick up something different. If you do weight training, do yoga, and vice versa. But do some physical activity, because I believe that will lend to some new circuitry firing in your head. And then number 2 is do creative stuff. Do something creative. We're all born artists. It doesn't need to look pretty. You want to sketch something, do it. Just go to the hobby store, buy some pencils and paper, and do it. If you know nothing about music, learn music. There are apps you can learn to play keyboard. But do something creative. In fact, that's my advice to everybody, honestly, to learn new things. We get kind of comfortable after the age 30. We know what we know, and we can coast to the rest of our lives without really learning anything new. Even in medicine, continuous medical education, we're learning more of the same. We're not learning different things. So I always encourage people, become uncomfortable. Learn glass fusing, silversmithing, sketching, digital art. Get uncomfortable and learn new things. And that leads to fresh new circuitry in your head to replace whatever is bringing you down. So again, short answer is ketamine allows a brief light into the darkness. And you have to work at that to get out of it.
Okay.
So Vafa described like 3 or 4 or 5 topics. Neuroplasticity is what he's talking about, and we believe that anybody who wants to learn violin or anything, it doesn't have to do with anything with depression, but if you want to learn how to cook, etc., learn a new language, you have to lay down new circuits, and you reinforce these over and over again. That's practice or focused practice, and you get feedback, and so you can improve your practice. And that's the neuroplasticity that naturally happens. We think ketamine may accelerate some of this natural neuroplasticity. And then Vafa is essentially saying, we don't want this to be a passive experience.
Right.
Here, Dr. Tadros and Dr. Foroughi, I'm gonna give you money. I'm gonna lay down. Just give me an IV. Give me an IV so I can just feel better. And although that's part of what can happen, it certainly is not the maximum that you can get out of the experience if you don't do something active like Vafa mentioned. It's the same thing with heart attacks. I tell people I can give you Lipitor after a heart attack. I can decrease your risk of a future heart attack. But boy, if you continue to smoke and drink and all that stuff like that, that Lipitor is not going to work nearly as well as if you helped it work. And that's what Vafa is saying. Help the ketamine work. Decrease or stop bad habits, bad behavior that's unhelpful, that sometimes is learned because you feel so crappy with your depression or your pain or your anxiety. And you're laying down new circuitry that it takes months to sometimes years to get some of to get the maximum benefit of all this stuff, your medicines plus all your habit changes.
Right.
I remind people that with any psychedelics, we can talk about this later, although ketamine is technically not a psychedelic drug, it has some psychedelic-like experience, a dissociative anesthetic. It's the type of drug that we can talk that affects the experience, the mindset and the setting of intention, and then the setting, which is the physical space, and then the dose that we choose with the patient. So several things help determine the experience, how pleasant it is, and what Vafa says that he alluded to, that sometimes your mind seems to be more open during or shortly after the experience, to see yourself differently, see your problems differently, and be able to essentially self-therapy is essentially what it is.
Yeah. So this is a lot more than just, administering a medication to patients. And I think that, sort of gets to our biggest point of difference, which is just the time spent with patients to help set some of these expectations, how
correct.
patients come in with good intentions and have realistic expectations about what their role is in this active healing process we're trying to engage people in, rather than, just passively coming in and receiving their medication.
That's right.
And I've said before on this podcast and in other places that I was a patient at this clinic back in 2017 too, and what Dr. Foroughi was describing in terms of that temporary reprieve from the those sort of stuck mental processes. That was totally something that I experienced during infusions, and then the importance of neuroplasticity. A lot of depression and anxiety is getting stuck in a thought loop.
That's right.
That becomes maybe a thought distortion that becomes self-fulfilling because it just replays over and over and over in your brain. A common example of this is just like persistent low self-worth. I'm worthless. I'm hopeless. Nobody cares about me.
That's right.
And that can feel so loud in your head. So that during an infusion of ketamine, a lot of that noise can quiet down for a little bit of time. And it sort of is accompanied by a quieting of your body. The sensations in your body are different and separate from what you're normally experiencing when that negative thought loop is going, which allows you, that moment of space and rest to sort of take a new perspective on some of the old issues that have troubled you before. And then the hope then is that people can capitalize on some of the traction that comes from these ketamine infusions.
Yes.
That was my personal experience too, that I was getting some really real benefit during the infusions to get that fresh perspective on myself, which helped me keep moving forward with healthier behaviors, drinking less, the momentum to keep moving forward. So,
and one of the things, and we've not said it out loud, but and I mentioned to both of you recently, one of the things I've heard probably 4 or 5 times, patients with one infusion, not necessarily from our clinic, but elsewhere and also in our clinic, their first infusion, if they've had suicidal thoughts, that seems to be the first thing that seems to improve.
Yeah, absolutely.
That noise in their head about low self-esteem, that there's life is not worth living, seems to go away. Probably the first thing that seems to go away. And
that's incredible.
That's
in
a
and of
big
itself.
weight off
That
people's
is,
shoulders, right? And that's the scariest aspect of any of the chronic pain patients or depression or anxiety. All these people are at higher risk of suicidality, certainly suicidal thinking, even if they don't act on it, and suicidality. So I want people to understand, whether it's us or another clinic, or but there's there may be some relatively quick relief. Not for everybody, not every single time, but yes.
Right. So we kind of backed into this discussion about our protocol, but I'm hoping you guys can talk more about this now. So someone's approved for ketamine, you think they're going to be a good candidate for treatment, Dr. Tadros, then what happens then? You hand it more off to Dr. Foroughi and
I hand them back to you
Aaron.
so you could schedule
Well, yes,
them.
to me, so I can schedule, yes, for sure. But then the treatment protocol, number of infusions, how often? You want to talk about that,
So
Dr.
once they get
Foroughi?
scheduled for the clinic, we schedule all 6 because timing is critical. Most
First
clinics,
is 6. I don't think
6.
people have heard that.
Yeah. So the original studies was done with 6 infusions. And, I tell patients it's not a magic number. They probably looked at a few different approaches, and they felt like by the number, if they did 1,000 patients, for example, people were still getting better after the 5th. So let's keep going and see where there's no longer any return on, benefit of getting these people more infusions. So they arrived at 6. Some people we've had patients who've gotten better with 1 infusion and they're one and done. But we still continue to do 6. So our protocol is 6 infusions over 3 weeks. Some clinics do it over 2 weeks. I think the last time we went to a meeting, it's about half the clinics do it in 3, half the clinics do it in 2 weeks. We do it in 3 weeks. When they come in for their first infusion, I do have about a 45-minute conversation with them. I definitely want the loved ones, partner, parent, spouse, in that 45-minute infusion. And I do look at, and I make a quick observation, the first 30 seconds of their body language. It is very important for both the patient and their support to be all in.
Yeah.
And I, when we've had patients who either dropped off midstream or really didn't get improvement, looking back, it's been the times that their support person, let's say spouse, was not in it. Their body language, they're turned 45 degrees away, their arms are crossed, they're looking up at the ceiling. So I do look for that, of that support person. And then same thing with the patient. Sometimes patients come in, because their spouse is tired of it. And they said, you have to do something.
Right.
We can't go on like this. So the body language is very important, the attitude, the tone of voice, the kinds of questions. So, and then I talked to them for about 45 minutes, setting the expectation and giving them homework, like I said earlier, about physical activity, about creative stuff. And then also telling them that to stay hopeful, in the sense that I tell them, if I bring 1,000 patients off the street randomly and give them ketamine, a lot of them will feel better.
Yeah.
For a little bit of time.
Sure.
A few hours maybe.
Part of that placebo effect.
Right.
Yeah.
And I think it's real. It's an upper. It's like acts like an upper. You're like, I got more energy, it seems like. But they will get better, but then they will get worse. And the next infusion will get them a little bit better, but then get worse. So imagine a sawtooth graph. You go up a little bit and then you come down. Then next time you go up a little bit and you come down. I tell them the slope of that is difficult to predict, i.e. how many infusions will it take for you to have, let's say, a 50% improvement, okay? It's difficult to predict. We've had headed out of the ballpark with one infusion. We've had people come in for multiple infusions before they have that eureka tipping moment, if you will.
Yeah.
So I tell them not to give up hope, because, A, they go home, they feel amazing that evening. Next day, boom, they're down. And that's sometimes devastating. They get hopeful for a few hours and they're step back. So my goal during that 45 minutes is to not only tell them what to expect, the nuts and bolts of what the infusion will be like and where we sit, where they sit, while they will watch, but also really more importantly, hang in there, be hopeful and optimistic. So it's a good long conversation. We take the patient back to the infusion room. While they're getting set up, I go back to the other person, the parent, the spouse, and I speak with them temporarily. Did you have any questions you didn't want to ask in front of the patient?
Yeah.
And sometimes I get additional information. And so I always give them an opportunity to say something without the patient being present. And then we go and start putting monitors on, and we have a nurse that kind of tag team, she and I tag team the patient, get monitors on, start an IV, get some baseline vitals, and then we're lined up for the runway, ready for the trip, if you will. And we start the infusion. Yeah. 15 minutes, it takes about 15 minutes to get the patient hooked up and IV started. Then the studies were done on a 40-minute basis for depression, so the infusion is exactly 40 minutes to the second. A pump automatically shuts itself off. We continue to give patients fluid, backup fluid, if you will, hydrating them a little bit, even after the infusion is stopped. And they recover, if you will, and that recovery is variable. Our average is about 35 minutes. Some people are ready to go much sooner, but I want to keep them at least 20 minutes, just kind of observing them. And then we do a quick questionnaire to kind of gauge the level of dissociation, and we can talk about that at some later point. But then we walk them out. They're going to be unsteady. I warn them, they're going to be unsteady. Don't run out of the clinic. I tell them, go straight home. Don't go shopping. Don't go eating. Go home, rest, eat something light, and take it easy with the rest of the evening.
Sure. And then we see for the most part that people are like good to go the next day. Like the tiredness is worn off, and any lingering side effects. Can you talk a little bit about some normal side effects that people experience?
The most things we have seen. I mean, if you look at drug inserts or studies, there's a list of 30 things that could happen. But what we have seen is nausea. Sometimes they get both sick to their stomach, if you will, both during the procedure or the infusion, and then sometimes in the evening. Being kind of sleepy a little longer does happen. It's difficult to predict. I think age has a little bit of something to do with it. So those are the two things we see. Just was tired all night and sick to my stomach. Very rare. I would say that's less than 5%, at least anecdotally from our end.
Sure, yeah.
And as soon as someone does complain that they got sick the night before, we do add kind of an anti-sickness medicine to the regimen.
Sure.
If they come in with a history of having sickness and nausea, we go ahead and start that anyway.
Yeah, absolutely. And you ask all those questions during your preliminary consultation and everything
Right.
too. So, how do you tell you alluded to this a little bit, that you're kind of grading you're helping the patient grade their dissociative experience on a scale. What counts as a good infusion? And then how do you make changes to the dose based on that feedback that you get from the patient?
Well, we do observe the patient, for example. So throughout the infusion, we'll see how sleepy they are, what kinds of things they talk about or ask questions. That in itself, obviously, we don't want them necessarily too sleepy.
Yeah, right.
We do want them not to be too fully awake, almost unaffected.
Yeah.
And so one of the beauties of IV infusion is that we can adjust course on the fly,
Yeah,
real time.
instantaneously.
In
It's
real
amazing.
time.
Yeah.
As opposed to other routes, there are other routes of ketamine, intramuscular or IM ketamine, nasal. Those are very unpredictable, and once you give it, you certainly can't take it out.
Back, yeah,
You
absolutely.
can always add to it, but then that becomes kind of complicated. But so we are observing them, how sleepy they are, how affected they are. We can give them additional incremental doses to boost them up a little bit. So again, that's the main reason, the main way of doing it during the infusion. And then once they recover and they're ready to leave, we do ask some questions. It's a subset of a bigger questionnaire that we do. That is, I believe the full questionnaire is 20 questions. We do a subset of them, selected questions, to gauge the level of dissociation. For example, did time move abnormally for you? Did you see things out of your body, have a floaty experience, out-of-body experience? Did objects, sounds, or colors appear different to you? Did you have any memory gaps? Did you experience any intense emotions? Those are all yes/no questions. And if they answer yes, then we try to rate it. Was it mild, moderate, severe, extreme? And we go with what they say.
Sure.
Even though we observe them to be a lot more intense in one of those questions, we go with what they perceived at. And so we get a kind of a total score, and we let that score try to guide us. If the score is too low, i.e. they were barely affected, we go up. And, being an anesthesiologist, safety is very important. And actually is the number one. During my conversation, I say, I guarantee your safety. I'm hopeful about you getting better.
Yeah.
But I tell them, when you are here, you are my son, my daughter, my brother, my sister. That's how I treat you. Family.
Yeah.
And I genuinely feel that way about my patients. So we do increase. We have a little protocol, a stepwise protocol. Generally, our first 6 infusions are under that protocol to begin with. We have an escalating dosing of protocol. We start with 0.5 milligrams and go up from there. We plan to finish at 1.25 milligrams
Per kilogram.
per gram. So I would say about a third of the time we stick to that protocol. More often than not, we are going up a little bit more quickly to make sure the patients get the benefit of the dissociation.
Yeah.
Well, we don't want patients to waste their time and treasure, money and time, of not getting the best possible experience during the infusion.
What Vafa says is that we believe, and other practitioners don't necessarily agree, that we believe that part of the dissociation, that's why we don't want them to be asleep, but part of the dissociation and their ability to contemplate and see themselves differently is part of the therapeutic benefit.
Yeah, absolutely. Yeah, I can confirm that from personal experience.
Thank
And this has been proven time and again in our anecdotal population. Patients that come through and they always dread going to Thanksgiving dinners with all the family because invariably a fight starts with a sibling that comes from a different state. And I do tell them, I do kind of, I guess, a mini talk therapy. I'm not a talk therapist, but I can talk. I have experience. I hear other people, so I share that experience. And they come back, after one of those meals and say, you know what? I started getting into that argument, but during one of the infusions, I was saying how can I not play the same role in this play that I've been an actor of for years? I stopped myself.
Right.
It's just a simple few thousand neurons, nerve cells in your brain firing left versus firing right. And that's it. So during these infusions, these people that have trouble with different kinds of situations, let's call it the potholes of life, they develop shock absorbers so they don't break an axle as they drive through it on the road of life. They become more resilient. They catch themselves. They become more compatible with regular traumas in life that we all experience every day.
I think anecdotally, the patients who seem to do the best with us are the ones who are working on integrating those experiences that they're having during the infusions into real life scenarios. So just like you were saying, helping to utilize that neuroplasticity to, make new thought patterns and new behaviors to change the role that they would normally play in some of these situations. So that's certainly critically important. All right. I'm going to hit you guys with a couple to close out here, hit you with some frequently asked questions because I get all of the questions all the time. And I think that it'll be great to just, hear directly some of these answers so that people can, refer back to them. So let's start with the number one question. This is always the biggest question. Why does it cost so much? Why is ketamine infusion so expensive?
Yeah, the ketamine, like I mentioned, is an inexpensive drug because it's generic. It's the delivery. Whenever you have a registered nurse, almost all our sessions are two physicians there. Probably 2/3, 3/4 of our sessions are two physicians there, the facilities, et cetera. So that's really what it comes down to is the delivery of the medicine. Because it's not FDA approved for depression, what happens is that insurance do not feel the need to cover it.
Correct.
So it tends to be a cash pay treatment.
Yeah, absolutely. And I think that's probably, that's been one of my biggest learnings in sort of educating some of our patients too, is that not every treatment that's available in the United States is FDA approved, and especially the ones that aren't FDA approved are going to be very unlikely to be covered by your insurance.
That's
so
correct.
You can always call your insurance company and see, but I don't think we've had any patients that have come to us that their insurance company is like, yes, I'll go
sometimes
ahead
they'll
with this.
have something called an HSA or FSA or MSA, so a health savings account or spending account, and sometimes we can give you a super bill and they can get some money back. That's money that they set aside pre-tax, so it's not really insurance; it's their own money.
Yeah, absolutely. So.
To put that in perspective about the price, if you go and buy a Subway sandwich, the actual food cost is probably, I don't know, someone's going to probably correct me, but it's about 25%. So the turkey and the lettuce and the bread. But, 75% of it is everything else, the rent, the utility, the accounting, the legal. Obviously the owner needs some profit. So, we were fortunate when we started that our biggest expense, which was our labor cost, was zero.
Yeah.
Our rent expense was very low. So, I was very sensitive about that. We were both very sensitive about cost. So, I did a survey, and there was an article that came out back in 2015, and the range of per infusion was back then $500 to $1,700 per infusion.
Per infusion.
We were well below that.
Right.
So when I did my survey, we were the bottom 5% nationally. Okay.
Yeah.
And really, we have not had any price increases since 16.
Yeah.
So yes, it's expensive.
Right.
But boy, we're down in the bottom again because we control. We control labor costs. Us.
Sure. Yeah.
Yeah, that's a reason for the high cost. It's everything else is that goes into it. The ketamine is pennies.
Yeah.
Although now, by the way, it's really become more expensive as the supply has kind of
Demand
limited.
has
So, but all the disposables, labor costs, all that. That's why it's so expensive.
Yeah.
So when you have child labor, delivery, an average delivery in the United States is about $19,000.
Yeah.
But if you have insurance, so on and so forth, out of your pocket, it's a lot less. it's still
It's still-
$19,000.
Yeah,
you know?
it still is a lot of money out of pocket
That's right.
as well.
Right.
Yeah.
So
People are used to giving their insurance card and getting a $25
Yes.
copay,
Copay.
and then they're
Yeah.
done.
Right.
That's what they're comparing against.
Right,
Yeah.
absolutely. And I know, Dr. Tadros, in your consultations, you're really good at helping to contextualize where ketamine treatment falls in terms of cost and in terms of other treatments that maybe a patient should pursue first, because cost is a real
That's right.
variable and a resource that has to be carefully considered.
I'm very frank with the patients, because not only is it the upfront cost for the 6 for induction or the start, but any boosters down the line. So
Yeah,
I want
absolutely.
I never want people to be more stressed because they're trying to get better.
Right.
That's just it's
Anti-therapeutic,
it's
yeah.
anti-therapeutic.
Yeah, absolutely. Okay, here's another frequently asked question. I've heard that ketamine infusions don't work if you're on antidepressants or other psychiatric medicines. Do I need to stop all of my other medicines to do this treatment?
So there are 3 categories of medicines that sometimes may affect the dissociation, and sometimes, therefore, the potential benefit. Dr. Foroughi and I believe that you should stay on all of them, and our rising dose protocol should be able to take care of some of that gap. The 3 categories are benzodiazepines. That's your Klonopin and your Xanax and your Ativan. The next one is your anti-seizure, mood stabilizers. They're typically anti-seizure medicines, but also includes lithium, which is not an anti-seizure medicine, but also Depakote and Lamictal. Those are, and then the next category is antipsychotics. That's your Zyprexa and Risperidols and Abilifys. A lot of atypical antipsychotics that have come out in the last 15 years. So those are the 3 categories of drugs that may interfere with your experience. Vafa and I just find that we can use the dose, we can manipulate the dose for the ketamine to get you where we need you to be. In certain situations, if you're on a very high dose of benzos, et cetera, I may point that out to the patient. But I never want, because almost all these patients have come to these doses, these medicines, through slow, difficult period, over time. So for us to have somebody hold it or stop it just would not really work in real life.
Sure.
Yeah.
And I think the patients may become kind of vulnerable in that period.
Absolutely.
As they're kind of weaning off or lowering.
Well, they get worse.
I worry for that.
What happens is that they feel worse for a variety of reasons, both the depression or anxiety, whatever, coming back, rebound sometimes, and then they say, well, the ketamine didn't work. Well, it's because you're also changing off of your other medicines or stopping your other medicines that had been helping somewhat. So then you blame it on ketamine not working, and
exactly.
other things were happening at the same time.
So I think I hear 2 answers there. One's that it kind of reinforces what you're saying about the importance of having a good psychiatrist or primary care physician that is regularly involved with you prescribing medications to do what they tell you to do as far as prescriptions.
Right.
And then the small chance or the small effect that those drugs might have on your dissociative experience with ketamine, we have a plan to mitigate that.
That's right.
And that is the dosing protocol. Okay, great. All right, here's one for you, Dr. Foroughi. What is the worst thing that can happen to me during a ketamine infusion, and what if there's an emergency?
Well, we are fully staffed and stocked with all emergency. We have basically a crash cart in the clinic that is the same kind that you would have at a surgery facility. So we are ready for any kind of adverse effect. But that's a tough question to answer, because the worst thing that can happen to you is probably on your way to the clinic in a very bad car accident. So I don't mean to be funny about it, but anything can happen, obviously. But we are very cautious. We're very careful. The most common thing that we see that needs treatment from our end, short of increasing or decreasing the dose of ketamine because it's not affecting them enough or maybe a little too intense, is really the slight increase in blood pressure that we see. Okay. 10 to 15% increase in blood pressure. Most people absorb that kind of increase because our blood pressure normally fluctuates. If you put a blood pressure cuff on you while you're running on a treadmill or doing workout, it's really high. And you don't want to live at that blood pressure, but it's really high during that time. But on occasion, the blood pressure does go up, and since we have access intravenously, we do have short-acting blood pressure medicine that we kind of counteract that, because we really don't want to lower the ketamine if they're getting the good effect from it in the state of kind of dissociation. So the most common thing we see is a slight blood pressure increase that we treat with temporary drugs.
The other things are sometimes nausea and vomiting. We have Zofran, and the other thing is some people have headaches, or who are typically people who are already migraineurs, people who have migraines. It may be occasionally, although we can use it to treat migraines. Some people who are people who tend to get car sick, seasick. That's the nausea, vomiting people. People who had previous problems with anesthesia; those are increased risk for nausea. And then some people who already have a tendency for headaches can get headaches, and we treat that all on the spot.
So
yeah, but additionally, I want to tell people that we are using this at such low doses,
right?
Okay, and it's such a slow process, and it's going through the IV, so we literally can on a dime stop, and within 60 to 90 seconds, whatever was happening is not happening anymore. So. Again, the patients are under a microscope. Every second we're watching them. So, bad things in healthcare, for example, does happen when patients are kind of out of sight, out of mind, and something is brewing up and you don't notice it.
Sure.
Whether it's their oxygen level, things like that. We are watching these patients every second. Every heartbeat.
Yeah, we have an EKG monitor on them continuously, a blood pressure
monitor,
oxygen monitor, blood pressure monitor.
So it is pretty impossible.
Yeah.
It's like
Very
driving. It's like
yeah.
driving a car. Can I get into a fiery car accident? Yes. But I gotta have my eyes off the road and texting or fall asleep behind the wheels. Yes, bad things can happen.
Sure.
So that does not happen. We got way too many eyes in the clinic on the patient at every second.
So a follow-up question to this then is, some people are concerned that they can get stuck in a bad trip forever or lose their minds or lose their memory permanently. Those are not things that we're seeing in our patients.
That's correct. Yeah, that's important to differentiate. A lot of people come to us already with memory issues.
Sure, yeah.
So whether they're elderly and have true dementia or pre-dementia type of setting or mild cognitive impairment, that's one thing. But the other thing, of course, a lot of people with depression have what we call pseudo-dementia, which is fake dementia. And so that's the other thing. So that's always a challenge.
It's kind of depressed executive functioning because their mood is so low.
Right.
Yeah.
They're distracted, they're depressed, they're focused inward about their problems and stuff. And so they tend not to focus about what people are talking about, et cetera, so they can't remember.
Right.
And so that's, So no, we do not see any. We've done it for 6 years. We have not zero people coming back and saying, hey, this was a big issue. I recognize that some people go get ECT before, during, or after seeing us, electroconvulsive therapy in select patients, and ECT, depending on how it's done, does cause memory issues. So you could have confounding or other issues coming up while they're getting ketamine or in between ketamine sessions.
And I tell patients if they're worried about too intense of an experience, I tell them most often it's me or the nurse reassuring them that you're okay, grounding them, if you will. And they say, oh, okay, I'm okay. And we kind of get it back under control. So that's first layer of kind of defense. The next is, if we have to, and we pause the infusion.
Yeah,
we
absolutely.
pause it.
Yeah.
And within literally seconds, they're like, okay. And then we either reestablish the infusion at the same dose, or occasionally we kind of reestablish it with a slower dose.
Right.
And then we also have a kind of an emergency drug, if you will, for a bad trip. And it's just a short-acting benzodiazepine called midazolam. And tiny amounts of that quickly calms everything down. So many layers. And I can tell you, I can count on kind of one hand the number of times we've had to use a benzodiazepine for a patient based on the thousands of infusions that we've done. I would say 95% of the time, just a reassurance kind of reorients them, refocuses them. And that's all that we have to do.
Yeah, absolutely. All right, I've got two kind of like easier ones here, and then we'll close out. So we get a lot of inquiries from parents, obviously, patients that have, children and young adult children who are, have tried everything, lots of different treatments and medications. So how old do you have to be for ketamine treatment, and can we treat minors?
We do treat minors with, but they're specifically come to us from a pediatric and adolescent psychiatrist.
Okay.
So 15 years. I think we've done 14. Actually, we have 14 who turned 15 while he was with us many years ago. He was a son of a physician, but typically it's 15 and above, and it's with the guidance and continued care of a pediatric and adolescent psychiatrist.
Right.
Absolutely.
Yeah.
There's not any physical or medical concerns about using ketamine on a younger patient or a smaller person or anything like that.
That's a very good question. So a lot of historically in psychiatry specifically, pediatric adolescents, and it's changed in the last few years, but pediatric and adolescents, they tended not to do big studies on peds.
Sure,
and also pregnant women, separate issue.
Right.
And we don't take care of pregnant women at all.
Yeah, we forgot to include that in things that would disqualify you
That's
if
correct.
you were pregnant or trying to become pregnant.
That's
but
correct.
It's not the right treatment for you.
That's correct. So historically, psychiatry tended not to do studies on young children, and they would extrapolate from adult studies about doses and effects on peds, which is not the best way to do it, but people were afraid to do studies on children. It's changed in the last few years, but because of ketamine's long history, and it has been used in peds, they use it in ERs, et cetera, that we have not seen any problems historically with the pediatric population with ketamine use.
Correct, absolutely.
And I think, too young of a child, because how ketamine works, again, this is almost anecdotally, where they have to work through certain things. I don't think, let's say an 11-year-old does have the experience,
they don't have
the maturity,
executive function to understand,
to deal with that, to use that opportunity that ketamine affords. So.
Yeah.
The 15-year-olds that we're seeing are physically also very mature, not mentally necessarily mature. They're 15-year-olds, but physically they're mature.
Yeah.
So they are adults, literally adult sized.
Yeah, absolutely. Okay, so last one would be, do I need a referral to get ketamine treatment, and does my doctor have to approve of my decision to try ketamine?
So because we don't work with insurances, there's no referral process in the sense of a formal referral. And people can get referred to us by a friend or a therapist, talk therapist, or a psychiatrist. That type of that's perfectly fine. And I missed this last part of the question.
Yeah, does my physician have to approve of my choice to do ketamine?
Right. Yes. I as we had said previously, I want the whole team on board, and I don't mind necessarily speaking to physicians or therapists, et cetera. But it's important not to set up a wall or tension between the patient and their regular physician or physicians or practitioners because they've chosen to do something on their own. I think it's just bad medical care. As an internist, I think it's bad medical care to not have at least people say, I don't know anything about it. I'll trust these people, or let me call them and stuff like that. But I need. Yeah, we can't have more tension in people's lives than they already come to us with.
Right, and of course, our role is not to take over their care.
Never. We don't set ourselves up as that, and we certainly don't.
Right, absolutely. All right, well, I want to thank you both so much for joining us today.
Fun.
I think this will be a really useful episode for a lot of people listening.
Thank you.
This was fun. Thanks for having me over.
Good. There's a lot of we kind of thought through some stuff, and it's interesting. It's when you say it out loud, you rehash things. Yeah,
it's good to reflect and tell the story, and I feel super proud to work on this team with you guys, and I'm just very grateful for.
Well, patients love you, so which makes our lives better, and so we're happy. Happy with the team.
And we love our patients. Yeah.
Yep, Erin, our nurse, who's been with us.
Yeah, I want to give a shout out to Erin. She does her own little thing with the patients. There's a number of patients that she interacts with during the infusion, and she's going to share some experience. After doing thousands of infusions, you pick up a little bit of something. And, my goal is to share whatever I pick up from some patients and share it across the board with other patients. So Erin does a wonderful job.
Whether it's us or somebody else, we believe that ketamine may be appropriate for a lot of people out there who are suffering and that have been through traditional therapies and stuff like that. So because a lot of people are not within earshot of us, but hopefully if they hear about it. I just got somebody from Orlando, a relative here, somebody from Orlando. We referred them to somebody to if it was appropriate, somebody down there to evaluate her brother, but to do it down in Orlando. So that hopefully relieves some suffering that couldn't be relieved with other techniques.
Yeah. If you would like more information about what we do here at Midwest Institute for Hearts and Minds, and if you'd like to maybe see about becoming a new patient with us, please reach out to us at our website at midwestheartsandminds.com. You can read a lot more information there about our treatment process and protocol. There's some frequently asked questions. You can also submit an inquiry there to us to get the process going on getting signed up for a consultation with Dr. Tadros. To see if you or someone you love might be a good candidate for ketamine treatment. Of course, we want your feedback and questions and interactions with us here on the pod. You can email us at notyourdocpod@gmail.com. That's notyourdocpod@gmail.com. Seth is working on a tight and tasty new website for us. So that is going to be forthcoming. It's going to be kind of a clearinghouse for all stuff Not Your Doc. So we'll have all of our our episodes will be posted there. It'll link directly to Dr. Tadros' blog, which is once again the inspiration for the Not Your Doc podcast.
Right. Just ways to get rid of things out of my head so I don't keep thinking about them.
Yeah, absolutely. But it'll be kind of a one-stop shop. And so we're excited about things to come. Thanks again, guys, for joining us.
Vanessa.
Dr. Charles Tadros and Dr.
Thanks,
Vafa
Vafa.
Foroughi. Thank you to Seth. I'm Vanessa, and we'll be back with you another time.
Bye. This previous podcast represents my opinions and the opinions of my guests. This is not medical advice, and I'm not establishing a physician-patient relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only, and because each patient is so unique, please consult your healthcare professional for any medical questions that you may have.